Thank you very much, dear colleagues. I would like to, and I'll try to keep within the time schedule, because up to now we are going very good. So what is ERAS, what is the title of this presentation, is also known as a fast track or enhanced recovery after surgery program. It was developed in Denmark by KLED, and initially for colorectal surgery, and almost everyone knows it, and many of us use it in colorectal cases. This program, it has many elements, more than 20, or they are preoperative, intraoperative, and postoperative. So it's about patient preparation, about anesthesia, about what surgeons should do, and what shall we do post-operatively to have our patient safely discharged home. And in 2009, Lassen, in the Archives of Surgery, published his report summarizing those items which should be included into the fast track or ERAS program for colorectal surgery. However, it's not a simple solution, because on this slide you can see what was the adherence of various studies to the elements of the ERAS. And the only element to which the adherence was 100% were the laxatives. In other elements, we have a range of adherence, and the weakest, as I see, is the matter of pre-medication, so anti-anxiety medications. Of course, it all started with colorectal surgery. However, why not to adapt it to other surgical procedures and other areas of surgery? After that, we had guidelines of the same or a similar program for liver surgery, orthopedic surgery, gynecological surgery too. And up to now, up to last year, there were recommendations of the ERAS Society for colonic surgery, for gynecological surgery, and also for pancreatic duodenectomy. So how to achieve the enhanced recovery without the increase of the complication rate. But there was not a solid evidence for gastrectomy, and even the published guidelines last year in British Journal of Surgery have only 5 recommendations which are specific for gastric cancer surgery or other surgery of the stomach, not only oncological, but the other 15 are, let's say, general to all surgical procedures within abdominal cavity. So what are the results of studies of ERAS in gastric resection? So we can look at the number of patients. The numbers were quite small, and we still wait for results of bigger trials which are still ongoing. And what were the elements of this reported trials in gastric surgery? So the adherence or the common elements was the avoidance or the early removal of drains, avoidance or the early removal of nasogastric tube, early enteral or oral feeding, and early mobilization. Of course, there is the difference between an avoidance or early removal of tubes, abdominal drains, or a nasogastric tube, so these are not equal terms. However, these trials resulted in a shorter hospital stay in patients who were treated with fast-track perioperative treatment in comparison to patients who had a classic perioperative care. And the number of complications or rate of complications did not differ between classical perioperative care and the fast-track one. Still, even if we have published guidelines, there are unsolved questions. What are the key elements for ERAS pathway in gastric surgery? And are benefits of ERAS similar for various subgroups of patients? For example, total versus subtotal gastrectomy. When you look at the guidelines of ERAS Society for Gastric Resection, it's a difference in the guidelines for subtotal and total gastrectomy. Also, there is a difference between laparoscopic or open access. And is the shortened hospitalization the only benefit? So, to solve this question, we looked into our own program in the department of early feeding of patients with after a gastric resection. So the elements were, as you see, in a group of 396 patients, which we excluded 43 due to the death without oral feeding or late oral diet after 7th postoperative day. So the study population was 353. And the early feeding starting in the first postoperative day was 185, and delayed feeding starting in the third postoperative day was 168. Clinical characteristics did not differ between groups of early and late feeding. It was the only statistical significant difference was the difference in tumor size in millimeters, and tumors were smaller in the late feeding groups. The others were similar. Then we looked at the outcome measures, and the rate of surgical complications was higher in the late feeding group, but the only specific surgical complication which was higher in this group was the abdominal fluid collection. In general, complications also were higher in the late feeding group. So the main complication in this group was pulmonary complication, so atelectasis or postoperative pneumonia. Mortality was similar, and other parameters were similar. However, we observed shorter hospital stay in these patients, significantly shorter. So we tried to look if acute fluid collections or pulmonary complications influence our results or not. So we excluded patients with this complication. So we have a group without pulmonary complications, and still in early feeding group, postoperative hospital stays shorter. And without abdominal fluid collection, we have the same. So the statistical difference in favor of the early feeding group. In conclusion, I may say that the implementation of ERAS program after gastric surgery is feasible, and in our series of patients is safe. The main benefit is decrease in postoperative hospital stay, and in some cases, postoperative complications. Now, this promising result still should be confirmed in the large, well-designed clinical trials using standardized ERAS protocol. So thank you, and these are two fathers of gastric surgery who worked in the same department I work. To the left is Ludwig Rüdiger, the author of a first gastric resection, and Jan Mikulic Radecki, also the father of the upper GI endoscopy. Thank you.
Thank you very much for a very interesting lecture, and the talk is open for discussion. Okay, there is a question in the back. And of course, thank you also for staying on time.
Thank you very much for this lecture. I would like to comment. Last Friday, we had the first Pan-Arab Middle East conference on enhanced recovery after surgery. Vinod was there, and Henrik Kellet and Ole Ungvist and the whole bunch of IRAS interested group were there. I just wanted to add that IRAS is a concept. It's not only designed, and this is, I'm quoting Henrik Kellet himself. He said, it's not about the length of stay. It's about the quality. As you know, as we all know, it's a perioperative strategies. They are all evidence-based, and they work synergistically to improve the surgical outcome and the length of, and shorten the length of stay. And it's not only about gastric surgery or colonic surgery. Now, and the second lecture of Henrik Kellet in the conference was about implementation of IRAS in major orthopedic hip and knee arthroplasty. So it's a concept which will, I hope, will be applicable in all types of surgery. And it's not only about the length of stay, it's about the outcome, it's a quality issue, it's a quality improvement for the patient care. And I welcome any surgeon here in United Arab Emirates or from the Middle East area to join us, because we are starting the IRAS Society here in the Middle East, which is chapter, an official chapter of the International IRAS Society. Thank you.
Thank you for your comments.